Shelley Hwang, you are the director of the Breast Oncology Program at Duke University. You're my guest now on the Audio Journal of Oncology in the wake of the San Antonio Breast Cancer Symposium that's just finished. You've been addressing something really crucial in breast cancer care, and that is ductal carcinoma in situ. It's a big enigma, isn't it? Can you tell me what was the background to this study that you've just published?
Yeah, Peter, hello. Happy holidays, and thank you so much for having me on the show. Yes, it's very exciting. I just came back from San Antonio as well, where I had the opportunity to present this study. And the disease that we're studying is ductal carcinoma in situ, which is a pre-cancer. It's an entity that precedes the detection of actual invasive cancer at the breast. So, as you know, breast cancer is the most common cancer that women get. In the United States, about 300,000 women are diagnosed a year, and about 50,000 women are diagnosed with DCIS. And it's an enigma, as you say, because we've been treating it as cancer and operating on it as cancer for decades. And this is the first time that we've put to the test whether we actually need to do that.
Right. In fact, a lot of women worry about it, and many of them worry needlessly. Is that what you're saying?
Well, yes and no. What we aim to do is to determine what would happen to women with DCIS if they did not undergo the standard treatment that we recommend now, which is surgery, and about a third of women have mastectomy for DCIS. What would happen if we just monitored them closely, like we're starting to do with prostate cancer? That was the question we wanted to ask.
Right. So right now, guideline therapy is to actually intervene in this condition. What exactly
Right.
does the guideline say?
The guidelines for anyone with a new diagnosis of DCIS is to have the area removed. It can either be with a lumpectomy, which is a small excision of part of the breast, or it can be a mastectomy. And about a third of women choose to have a mastectomy for a diagnosis of DCIS, which is quite a significant surgery for many women and really changes their lives forever.
What was the evidence base, or what indeed is the evidence base for setting up that guideline?
Well, it's really interesting you would ask that because we really don't have any guidelines. For as long as we've known what DCIS was, we treated it like a cancer, and we never put to the test what would happen if we treated it a little bit differently, like a risk factor, like a genetic mutation, for instance, rather than as a cancer itself. Because what we're starting to understand now is that not all DCIS is destined to become cancer. So for people who have the kind of DCIS that has a low risk of ever becoming cancer, all the treatment that we were recommending for them really doesn't help at all. So this is what we were trying to test in our study.
Right. Now, you were looking at low risk women, so they were scored for risk, were they? And what did you do with them?
Yeah, actually, Peter, that's really important because there are at least two main groups of DCIS, those who are at higher risk for developing invasive cancer and those women at lower risk. And we definitely wanted to reduce any potential risk of future cancer. So we limited our study to women with low risk DCIS, as you say. I think that's a very important fact that I think many people might kind of get confused about. But yes, it was only low risk DCIS that we enrolled in our study.
What about receptor status, for instance, and also HER2?
Right. So one way we defined low risk was that patients had to be have estrogen and progesterone receptor positive DCIS, and then there's also the issue of grade, tumor grade, and it had to be non-high grade. So all patients had either grade 1 or 2 DCIS.
So tell me about the cohort and the randomization.
Yeah, sure. So we started the study in 2017, and it was a prospective randomized study. And it was a non-inferiority study in that we were testing active monitoring against usual care and tried to test whether the two were equivalent or that active monitoring was non-inferior. It was a pragmatic trial because we knew that there were many patients who were going to be assigned to one or the other arm randomly in the randomized trial. But there would be women who would not adhere to the randomization because like many trials that compare surgery to medical therapy, you can't blind the patients or the investigators. I mean, it's clear who had surgery and who did it. And since everybody comes into the trial with a little bit of bias about which one they'd rather have, we had about 30% crossover where patients who are assigned to one group actually did what the other group did. So we considered that in the design of the study. But the way the study was designed is that there were two groups. One group randomized to usual care, including surgery and radiation, and the other group randomized to active monitoring, and they only had surgery and radiation, the standard treatments that we give patients, if they developed invasive cancer. And the primary endpoint of this study was to determine the rate of invasive cancer in the two groups.
Did you find that patients often had preferences for one approach or another?
Yes, and I think that's the real world. I think when you have a study where the two groups are so different and patients come in with a preference, they're going to do what any normal person would do, and they would exercise their preference regardless of whether they're in a clinical trial. I mean, they all knew that it was a randomized trial, but we also got consent to follow them long term, even if they did something different than what their randomization would indicate. So we followed all the women. We had almost 1,000 women enrolled. We randomized 957, and we looked for the rate of invasive cancer in the two groups. And we did two different kinds of analyses. One was just the standard intention to treat analysis, where you just analyze according to the randomized group. And then, very importantly, we did a separate analysis called the per protocol analysis, where we only analyzed those patients who got the treatment that they were assigned to. And because there was a fair amount of women who did not adhere to the randomized protocol, the per protocol analysis was really important as well.
To complicate matters more, did endocrine therapy come into this too?
Yeah, you've done your homework, Peter. We wanted to make it a pragmatic study, so it wasn't a test of endocrine therapy versus surgery. That's a different study. We just wanted to test the proof of principle that if women did not undergo surgery at the outset, that they would not do any worse than women who had surgery from the time the DCIS was diagnosed. So that was the test. And if women, together with their physicians, felt that they wanted to be on endocrine therapy, or that it was appropriate for them to be on endocrine therapy as in a prevention type of situation, then that was allowed. And it actually was interesting because there was about 70% use of endocrine therapy in both arms. So there wasn't a big mismatch between groups.
You had nearly 1,000 patients, a good sample. What results did you get?
Right. So in the first analysis, which was the intention to treat analysis, we found that there was no significant difference between groups in terms of invasive cancer. And in the per protocol analysis, the difference between groups was only 1.7% in the intention to treat analysis, with a lower detection of invasive cancer in women who are undergoing monitoring. In the per protocol analysis, what was really interesting is that there was about a 5% difference lower in the group that had active monitoring compared to those who had surgery. And that might be a little bit counterintuitive, but the women who had cancer in the surgery group had them at the time of surgery. It was detected or upstaged at the time of surgery. And the reason we didn't see that same rate in the active monitoring group was probably because the endocrine therapy treated some of those cancers.
And how statistically significant was this result?
So in the intention to treat analysis, the difference was not statistically significantly different, and it definitely fulfilled the bounds of non-inferiority. So we achieved that goal. Interestingly, in the per protocol analysis, where patients were analyzed according to the treatment they got, not what they were, the treatment that they were assigned to and then they got, it was statistically significantly better in the group that had active monitoring. Now, I don't want to make too much of this because it's a short 2-year outcome. We just want to test for feasibility and safety, and that is absolutely what we accomplished. It appeared that this was a safe protocol, that women, just like men with prostate cancer, could be safely monitored using the protocol that we set up for this study. And we'll be really interested to see what happens when we have longer term follow up. Now, if these results are durable, and not just in 2 years, but in 5 years and 7 years, I think it may very well be a practice changing study for women with low risk DCIS.
At the moment, is it too early to actually
I
recommend
think it
that people
is.
consider
I,
active monitoring?
I think it is. I think it is. I mean, I think women enrolled in the study because there were definitely women who are interested in an alternative to surgery. But I think these are very short-term results. They're a very important first step, but I don't believe this is long enough follow-up for women to change their treatment recommendations. That hopefully will change when we get more data. And this is not to say that everyone with DCIS should have active monitoring. I think it should be something that if the results are durable, it should be offered as an option. It just gives women more options about how they would like to reduce their future risk of breast cancer.
Now the story is out, though, so do you think you'll get any patient pressure on this already?
Oh, yeah, Peter, even before this study came out, even before we designed the study, the motivation or the inspiration for the study was women who had come to me and they had made the decision. They knew this was a precancer. They did not want surgery for it. They didn't want to lose their breast over it. And so I had patients who were on active surveillance, mostly because they just refused to do surgery. And many of them have been perfectly fine. And I continue to follow them regularly.
So
So I think many of us may see women in our office who have made the decision to not do surgery. I think we should caution them that this is very early. These are early 2-year results. But we do have a protocol as a result of this study about how to follow these patients carefully. And the other important thing that we demonstrated is that